Fine.
Good afternoon. Welcome to everybody out there who is watching. My name is Brendan O'Connell, and I am a bariatric surgeon at Cooper University Hospital. I'm here with one of my colleagues.
Hi, I'm Josie Raum. I'm one of the dietitians here at the Surgery Center.
And we are going to present some information about bariatric or weight loss surgery. And I would like to start off by saying that there's a lot of patients out there who will come and attend one of our seminars to learn about weight loss surgery. Many times these are people who have been having trouble with their weight for a considerable amount of time. It's not often that people wake up one day and think, hey, I think I'll have weight loss surgery. This is something that people have maybe considered off and on for many years, and they are now coming to the point where they really feel like they need to do something about their weight. I see people all the time who are not sure if they should have weight loss surgery, if they're a good candidate, and really I think the first thing to do is to sort out who is a candidate for surgery and who is not. The first thing we need to do is see if you weigh enough. We will measure your weight and take your height, and we will calculate something called the body mass index. And if that is 40 or higher, then you are in the category of morbid obesity, and in general that's all you need to qualify for weight loss surgery. If your weight is a little bit less than that and your body mass index is in the range of between 35 and 40, then in those cases you need to have something else in addition to the weight in order to have surgery. And the main medical conditions that will help you to qualify are type 2 diabetes, or obstructive sleep apnea, or hypertension, or cardiac disease. And if your weight is such that your body mass index is below 35, then you will not be a candidate for any kind of weight loss surgery. So that's really the first thing, is just to sort out, who's a candidate for surgery and who is not. Usually our patients will be somewhere in the neighborhood of 100 pounds or more overweight. And quite often they will have one of those medical problems I talked about, like diabetes or sleep apnea or high blood pressure. And also a lot of our patients will have acid reflux problems. They may have high cholesterol. They may have problems with their knees, joints. A lot of times people are sent to us because they maybe need a knee replacement or a hip replacement, and the orthopedic surgeon has wanted them to come and get weight off before they have their joint replaced. Or these may be patients who are sent to us from a GYN doctor because they're having a lot of problems with something called PCOS, or polycystic ovarian syndrome, or infertility that is related to excess weight. So we see a wide range of patients here with a lot of medical problems. It's not just that they are overweight and having trouble with their weight, but that weight is damaging their health, and they come to us to see if they are somebody who could benefit from one of the operations that we provide. At this point, I would just like to talk a little bit about the different surgeries that we will talk about. So if you are considering having weight loss surgery, the next thing to do is understand what are the options that are out there. I have brought with me a little prop of something called a lap band. So, some of you out there may have heard of this before. The lap band is really a surgery that we don't really offer anymore at this point. But a lot of patients come in asking about a lap band, and also, a lot of patients will come to us because they may already have a lap band in place. The band is a foreign object. It's a little ring made out of a rubbery substance called silicone, and this gets inserted around the upper part of your stomach, and it is tightened up over time so that it will tighten down on the stomach to try to limit how much food you can fit into your stomach. Now, unfortunately, we found that there was a high rate of us having to remove these bands because they would slip out of place, and they tended to give people a lot of problems with acid reflux, and also, in many cases, the weight loss was not all that great with this device. And so we have just sort of stopped offering this as a primary procedure to people. But we do see a lot of patients who have bands, and we may be seeing them because they need to have their band removed, or they may be interested in going to a different type of surgery. And so I just mentioned this to start with, and the principle behind the band is that it's trying to limit how much food you can get into your stomach. And that same principle, it applies to the other operations which we do.
And just to mention something about the lap band, we will work with patients that come from an outside program into our program that aren't looking to have the lap band removed, but maybe have just been lost to follow-up with their previous surgeon. So if you still, want to follow a surgeon with your lap band and want to have follow a dietitian, work with your diet, work with the lap band that's already in place, know that there still is a place for you to work with someone on that, and it may not be necessarily something that we will remove if it's not giving you problems, but we can help work with you and work with the lap band to help you reach your weight loss goals with it still.
Yeah, it's probably one of the most important things to consider about this surgery or any of the surgeries that we offer. The most important thing as far as long-term losing weight and keeping it off is following up and keeping up with good dietary habits. We will have you seeing a dietitian in the preoperative period of time, but also you're going to be seeing these dietitians for the rest of your life. And it's that support in as far as changing your dietary habits and being able to stick to those changes that are going to help you to have a good result from any of these surgeries. At the end of the day, it's less important about which surgery you have. It's more important about how committed you are to changing your diet, because we see people lose weight and put it back on with any of the operations that we do. And the main constant, the main thing you can control is how you're able to work with our dietitians, change your diet, and make sure you're keeping to that healthy, nutritious diet that's going to keep the weight off long term.
That's 100% true. So a lot of times these next two surgeries that Dr. O'Connell's going to talk about, it doesn't just end with the bypass and it doesn't just end with the sleeve. So even though he'll talk about how they help you lose weight, it's always connected with that healthy lifestyle to help take the weight down and keep it off.
Yes, very good. I have a couple pictures, and I'm not sure how well these are going to project, but the operations that we do are all performed laparoscopically pretty close to 100% of the time. What these illustrations are showing are the abdominal wall and how the incisions would look after surgery. And what I tell people is that for the most part, most people we're going to be able to do the operation laparoscopically, which means that instead of making a big incision down the middle of your abdomen and going in there with our hands, instead we're going to make 5 or 6 small incisions. Each of these are about an inch or less, and we're going to be able to put a video camera inside your abdomen and go through the other areas with our other instruments that enable us to go inside and do the surgery that way. In some cases, we always tell people there is a possibility that we might need to convert to an open procedure and get in there with our hands, but it's pretty close to 100% of the time that we're able to do the operation this way. And as long as we're able to keep these incisions small That's something that's really going to help with less pain afterwards and a quicker recovery and a quicker time in the hospital. This technique applies to both of the two main operations that we do. So whether you chose to have either a gastric bypass or a sleeve gastrectomy, most likely we're going to be able to do the operation this way. The sleeve gastrectomy is the first operation that I'll talk about, and this is an operation that really is designed to make your stomach smaller. Sometimes people hear the name sleeve gastrectomy and they think that this is some sort of foreign object, some sort of wrap that we're putting in and wrapping around the stomach to make it tighter. But that's not the case. What we are doing with a sleeve gastrectomy is we're going to go in and we're going to remove a large piece of your stomach so that your stomach, which is drawn here in this drawing, we're going to remove a large piece of it, and the remaining portion is going to be about the size and shape of a small banana. And we're taking your stomach, which is about this big, and we're making it into about this big. And that is going to limit how much food you can eat, and it's also going to reduce your appetite so that you're not starving all the time. The stomach is responsible for secreting a substance that causes us to get hungry. And so by removing a big piece of it, making the stomach smaller, we're lowering that hormone. And most people who have this operation will tell me that their appetite is much reduced after surgery. This particular operation takes about an hour to an hour and a half of operating time. We would keep you in the hospital overnight, and most likely you'd be able to go home the next day. The main way this works is by giving you something we call restriction. So you're really going to feel it after this operation, where you go to eat and you're only going to be able to eat a small portion of food before you start to feel full. And so it's going to limit your food intake, and that's really the main way it's going to help you to lose weight. Sleeve gastrectomy has become a very popular surgery for us in the last I would say somewhere from 7 to 10 years. It's really gained in popularity. I feel like a lot of patients who before were maybe people who were choosing to have the lap band or maybe choosing to have the sleeve at this time.
I think people feel really comfortable with the sleeve because it's just such a, clean kind of idea of just removing a piece of the stomach, and that's it.
It's pretty easy to understand, I think.
Yeah.
And certainly the feeling out there among the public is that this is the safer surgery to have, and and I think that's probably true. The sleeve does have a very low rate of complications. It's a relatively quick surgery. Even in patients who have had a number of previous surgeries already in their abdomen, still most of the time we're able to do this laparoscopically. There's really two categories of people who I caution against getting the sleeve. And one is people who have a lot of problems with acid reflux. So if you have acid reflux, heartburn, these types of issues, the sleeve has the potential to sometimes make those things worse. So if you have those problems, we would most likely be sending you for an endoscopy test. So sending you to a GI doctor who would put a scope down and examine the lining of your stomach and your esophagus to see how bad the damage is from the acid reflux. And if it's severe or even moderately severe, then we would probably recommend against the sleeve, because I have definitely seen patients where they've had a sleeve and they have some reflux, and now afterwards their reflux is really getting out of control. And sometimes we have to convert them from the sleeve to the gastric bypass operation.
And I think you brought up a good point when Dr. O'Connell said we're going to send you for testing. Just know you don't have to have the answers when you're coming in. You don't have to know what type of surgery you want. You may feel like the sleeve sounds really good, and that might be great. We're going to run through all of our tests anyway, just to make sure that you definitely can have this surgery and have it safely. So even if you're not sure if your reflux is bad, or is like, how bad is my reflux, like, we're going to be helping you figure that out and kind of working with you the whole time. You really don't need to make a decision until we have all the testing complete, and even when you come in for your consult, that might just be the start of that thought process on what surgery type to get.
Yeah, that's a good point, Josie. The other category of people who this may not be the best surgery for are people whose weight is getting into the range where their body mass index is starting to get higher than 50. That is just an arbitrary number that I, look at to say maybe this is not going to be enough to give you enough weight loss to get out of the range of obesity. The weight loss with this sleeve surgery is usually somewhere in the range of people will lose about 55 to 60% of whatever their excess weight is. So if your body mass index is 58, that may not be enough to get you down and lower your body mass index to where you're making a difference in your overall health. So that's just another thing to consider. The other surgery I would like to bring up now is the gastric bypass. So this is the other main operation that we do. You'll hear different names for this. Roux-en-Y gastric bypass is the official name. And this is a little bit more complex surgery on the inside. There's a few more steps to it. The first thing that we do is we will separate off the upper part of the stomach away from the lower part. And really what we're doing here is we're creating you a new stomach. And the new stomach is going to be about as large as an egg. And that is the part of the surgery that's really going to limit how much food you can eat and give you that feeling of restriction and lower your appetite. The second part of the operation, and this is where it's different from the sleeve gastrectomy, is that we then will go and rearrange the upper portion of your small intestine so that you will not be absorbing as many calories from the food that you've eaten. So we measure down into the small intestine a certain distance, and then we will divide it in half. And we take the lower portion and we bring it up and we make a connection into that small egg of a stomach. And then we need to make a second connection lower down in your intestine to sort of complete the circuit. And when we're all finished with this, the food that you eat will go into the small egg-shaped stomach, and then it's going to pass through that first connection and go on down. What it's doing here is it's jumping over or skipping over the majority of your old stomach so that food doesn't go through the old stomach anymore, and it also does not go through this first section of the small intestine. All those things put together mean that you're going to be eating less food, and in addition to that, you're not going to take in as many calories from that food that you have eaten. The gastric bypass is really excellent at getting rid of acid reflux problems, and the reason is that the majority of acid is going to be here in this lower portion of the stomach. And so once we separate this off, this acid has no way to get back up into the throat. It just flows down the intestines. So this is really very good for that issue. It's also a very good surgery for people who have type 2 diabetes. Probably a little bit more so than the sleeve. I see better resolution of diabetes with the gastric bypass. And that's probably because there's very excellent weight loss with this surgery, but also because of the way the nutrients are diverted through the intestines. There's something else about this surgery that really helps with diabetes. People who have something called gastroparesis as well, the gastric bypass is very good. And anybody with any sort of swelling issues, this may be the surgery that we're going to recommend for those patients as well. the weight loss with the gastric bypass tends to be a little bit more and a little bit faster than what we see with the sleeve. People will lose somewhere between 60 and 80% of their excess weight, and you'll lose that in about a year to a year and a half time. I think one of the things that I would say about the gastric bypass is I see a lot of patients and they come in and they say, I don't want that, because they know somebody who had it and they don't want to lose too much weight. They
don't want to look sick.
Right, they don't want to look like a skeleton. That sort of thing.
I think that's a big worry. I mean, you're doing this not only for your health, but you don't want to look unhealthy. You don't want to look like, you want everyone asking like if you're sick.
I sort of have a hard time answering people about that because it's hard to know what was going on with that particular patient who maybe looked sickly or lost too much weight. It may be that they were having a lot of problems with their gastric bypass and they were not able to eat healthily. One of the big ways to avoid having problems with either the gastric bypass or the sleeve gastrectomy is to avoid certain risk factors for those problems. And probably one of the biggest things is smoking that I see. Patients who smoke, we require that they stop smoking in order to have the surgery, but if people then go back to smoking afterwards, this can cause ulcers in their stomach, or it can cause the connection to become very narrow so that they can't get food in. And this is one of the biggest preventable risk factors for problems related to surgery. Also, if people are smoking and they have the surgery, they're going to be more at risk for problems with their healing right after they have the operation. So smoking is really a big thing that we will really look at and try to help you to quit that prior to undergoing one of these operations.
I think another thing that people worry about a lot when they've seen other people have surgery, or you yourself may have had surgery in the past, and the big thing is weight regain. It's a very, very real part of life in general, and after bariatric surgery is no exception. It doesn't mean that your surgery's failed you or that you've failed. It just means that you need some type of support that maybe wasn't present at that time in your life. I think everybody's journey is very different, so don't compare yours with anybody else's. But we did have a really good question come in about somebody that had surgery in the past and has had weight regain. Like we said, that happens. We work with that you are in no way an outlier. But kind of nervous about coming back in to see us. One, the main reason is they're afraid we'll have to undergo another surgery, getting cut again. Most people are nervous about talking to the dietitian because that's actually where we'll send you first. When somebody joins our program that has had surgery in the past, and maybe it may not be from a surgical point of view, but maybe we start out with weight regain, that's why you're interested in coming to Cooper, we would have you sit down with myself or another one of the dietitians and kind of work through where we can help you, where we can support you to get you to those healthier choices and get you back towards your healthier goal weight. Everybody has their own life stressors and their own needs, so we really want to focus on you and what you need. If there's a surgical intervention that needs to be made, you will obviously be seeing our surgeon too, and you'll kind of walk them through how you could determine if there's a surgical intervention.
Yeah, absolutely. This is a very common thing that we will see patients for all the time. People who have had some kind of bariatric surgery, be it a gastric bypass or maybe a sleeve or maybe a band or maybe one of the other older bariatric surgeries that are no longer done anymore. And they had the surgery, they lost weight initially, and now they have put all that weight back on. And what to do about that? So, the first thing is to try to just figure out what type of surgery you had. And there could be a problem with the operation that might be something we're able to fix surgically, and there are some different imaging tests that we would send you for to try to just learn a little bit more about what kind of surgery you had. We might try to dig up the old operative report from the old surgeon and try to figure that out and see if there's any surgical problem that could be fixed. I mean, sometimes some of the older techniques, there are common things that can happen that can cause weight regain, because now food, instead of going through the bypassed area, is now going through the old pathway again. Many times we find that it's just what somebody needs is just to get back on track with seeing the dietitian. And so as long as there's no surgical problem that needs to be addressed, then I think seeing the dietitian and trying to get back to some of those principles from when you first had the surgery, to see if we can get your weight going back without surgery. And I always tell people, any kind of redo surgery always is a higher risk operation than when we do things initially. And so redo bariatric surgery is definitely something that carries a little bit higher risk. Now, if there's a problem and we need to go in and address it, then the benefits there outweigh the risks. But I do see a lot of people who come in and they say, I need a revision, I put on my weight back on. And that's probably not the first thing that we're going to jump to. As long as you're not having a problem, we're probably going to first try to get some of that weight off by non-surgical means, having you work with the dietitian, etc. So that was the question we got?
That was our main
Thank you.
question, and and there'll be other support services that we can offer patients coming in. We have fitness classes, and we can teach you how to cook. If your thing is microwave meals, maybe it shouldn't be anymore. We can figure out different ways to eat. If you need an actual meal plan, and you have to follow a meal plan, we can make one for you. But we should also think about ways to improvise off of that. If you want to go out to eat more often, we can work with you on that. The beauty of it is we can really customize it to you, but we can't if you don't come in. So,
and I think the greatest thing is our patients are in frequent contact with our dietitians. We have Josie, we have 2 others, and
we're very annoying, and we'll find you.
These guys are constantly contacting, either by phone, or they'll use email or apps where people are able to use something like MyFitnessPal and track what they're eating. Our dietitians can access that, send you back pointers. People will call and say, they'll send through their phone pictures of labels if they're in the grocery store. Is this okay? And I think that's one of the best things about how our program is set up. So people really get a relationship with the dietitian, and that's really important. We're running kind of short on time. This went pretty quickly, so I'd just like to throw out there that anybody who might be interested, we do have free information seminars where myself or my partner, Dr. Patel, will give a talk for about 45 minutes to an hour. It's a non-threatening way to just come in and hear about our program and what the process is like going through this, or if you like, just give a call and you can make an appointment and you would have a consultation with either myself or Dr. Patel, and we can just really kind of look at what your particular medical issues are and see if this is something that could be good for you.
And I just want to remind people that it's never really too late, and you're never really that far gone. Where if you've had surgery or thinking about it, it's always worth it to just come in and find out more. It's always worth it. You haven't crossed a path to we can't help you. I'm pretty sure we can find a solution.
Yeah, absolutely.
Yeah. All right. Well, thanks for visiting with us today.
Yeah, thank you.
Thank
Have
you.
a good day.